Hi, everyone. Thanks for joining us again on another episode of Overfilled, the podcast. I'm Brooke Messer, and I'm here with Jason Jedlicka, and we're here to talk about all things Overfilled from our specialty contact lens experiences. So we're going to share what those experiences bring to us, both personally and professionally, in some great ways. And today we're going to talk about one of our favorite and most passionate topics. To quote Jason from a 2023 ICSC education that he gave. He said, "The limbus is a wild place." And so today we're going to talk about all things limbus in scleral lens fitting. And it's funny, we talk about these we mention these like small topics like the limbus, for example, and it can really turn into like an hour of conversation around understanding lens design, how it hits the front, how it hits the limbal area, lands on the sclera, all those things. So I'm sure it'll turn into a good conversation and hopefully you can take away some tips. Before we get started, though, let's review what has overfilled us since the last time we've chatted. It's been a while. We've had some travels, and so it's been hard to connect on our typical Friday. So, Jason, why don't you tell us what you've been up to and what's overfilled you lately?
All right. Well, this last week, I got my third oldest son, who is in the Army, was home for the week with his girlfriend and became his fiance while he was at our house.
Yay! Congratulations.
So we have a daughter-in-law to be now, and their wedding's actually coming up already in 2 months.
Okay.
They're doing it quick.
Yeah.
And I guess
is she in the service also?
What's that?
Is she in the service also?
She is not.
Okay.
She's actually a first responder though too, which is kind of cool. She's a firefighter.
Oh, very neat.
So we had them at our house for the week. We got to have a lot of fun with them and got to see them get engaged. So it was a very fun personal week.
Wonderful. Yeah. And how's Ari doing?
Ari is doing fine. He's growing. And did we talk about the fact that he has a cleft lip, right?
Yeah, you mentioned that no other palate issues, just the lip.
Yeah.
And that he was doing good otherwise.
Yeah, he's got tape he wears to pull the tissue together. And then I think as far as I know, they're still scheduled to do surgery in about 5 weeks to repair it now. So all is going well. He's gaining weight. And so everything's on track to do the procedure. So
excellent. Yeah. Good.
Life is good.
Awesome.
How about for you? What's overfilled you in the last
few weeks? It has been a busy month. Got to visit my parents while they were in Arizona with the kids. And so Brian and I went down there and, got to do all the Arizona things, swimming and all that kind of stuff. I also have visited Poland since the last time we chatted, which was fun. I went there with one of our Bausch & Lomb besties, Carrie Rivera, and we hosted a workshop for some local fitters. We've from a Zen lens perspective, as many of you know, the three of us, Jamie, Jason, and I, we have a good relationship with Bausch & Lomb, and so we're always excited to, educate others about Zen lens. So it was great to get some hands-on education. The practitioner that hosted the workshop for us brought in 5 great patients. Nice. They were like really difficult KC, mild KC, post-graft, high astigmatism, and they all just it was really good. And the other thing, which doesn't always happen, again, the beauty of the Zen lens is that it's built so that you can fit almost every eye out of that fit set. And we did. We had to work our way through. Sometimes we started with a smaller diameter, went larger, or vice versa, started small, went larger, went from, spherical chamber to bielevation chamber, toric haptic. It was, we literally used the whole fit set. So I found that super rewarding to be able to like walk people through and actually have lenses in the fit set that made sense. Okay, what are we going to do next? Okay, let's pick this one. And then we saw what we wanted to see based on the changes we were making. And so everything went just super smoothly. And Jamie and I actually get to go back to Poland next week. And we're going to follow up on those connections because she had been to the Netherlands earlier last month too. So we're both following up on those connections that we had made in that area to just continue to educate those, see how they've been doing since we visited with them. So jet setting once more. Yep.
Yeah. And in fact, we were all out of the country on the same day a few weeks ago. You were in Poland. I was in Austria, and Jamie was in Canada. That great, crazy wild nation of Canada. But we were all out of the U.S. on the same day at different places. It was fun.
Yeah, and again, it's such a great thing to be able to sit back and pause and be like, wow, like look at what this career has become. Just I don't know, optometry can seem so, or like, oh yeah, I'm an optometrist. And they're like, yeah, glasses, it's like, actually,
Mhm.
no, like it's
Yeah.
Poland and it's UK and it's,
Well, you know how you get started down that road, right? You do a
oh,
residency with somebody
yes.
like you.
Oh yeah, thank you for
Buddy,
that.
come on, get that residency filled.
Yeah, we had a couple people reach out this week.
Good.
So yeah, for those of you who don't know, unfortunately, my residency position didn't fill. Um, I'm a firm believer that the person you match with in residency, it's just the way it's supposed to happen. So our person's out there somewhere, but we did have some people reach out recently, so we're chatting with a few. So hopefully within the next month, we find somebody that was outside the match, and
Mhm.
the right thing comes along. But I totally agree with you. Doing a residency is such an amazing door opener, and that's how you get to meet the people that continue to open doors for you, just like you have done for both Jamie and I,
Mhm.
and just really ignites a passion for the profession and makes it so much more fun to have those
Absolutely.
relationships.
Absolutely. All
All
right.
right,
Let's
let's
talk Limbus.
talk Limbus.
Do you want me to show the slide you got here?
Sure.
Okay.
And so we have this eye right here, and this one is actually I fit a couple years ago. I just think it's a good example, and I bring it up to, when I'm teaching residents sometimes about, we see it's easy to talk about blanching when it's at the edge of the lens. It's like impinging, digging in. But sometimes we get this like perilimbal injection or
Mhm.
vascular congestion. And it's like not always easy to know what to do. I think the next slide shows
Mhm.
the upper part of the eye. So again, like the edge doesn't look too bad. Maybe there's a tiny bit of edge lift, but
Mhm.
the and the vault is fine. I didn't upload those pictures because it's not worth showing. But it's kind of like, what do you do when you see this type of congestion? Because the patient, their main complaint is redness. It's like, yeah, it feels
Mhm.
fine, my vision's fine, but like people ask me if I'm tired taking drugs, like that
Right.
kind of thing. And it's like, what do we do? How do we tackle this type of perilimbal injection? And sometimes it's hard to know exactly what to do. Like, is it an eye responding to dryness, the material, the filling agent, solution incompatibilities? Because all of those things are easy things to switch, and that's probably what I would do first. But let's say they've tried a few different combinations of things, and so we're trying to decide, well, maybe it is the fit of
Yeah.
the lens. And so, how do we relieve some of that vascular congestion? What steps would you take first when you see an eye like this?
Yeah, I think there's two possibilities that jump out with regards to the limbus in particular, right? So the first one is that you are not vaulting the limbus. You've actually hit the peripheral cornea with your lens. And that's pretty easy to tell, right? Because if you actually are landing on the peripheral cornea with any amount of pressure at all, you're going to cause mechanical like bullae will
Mhm.
form where that landing occurs. So if you saw this patient, they had their lens on for at least a couple of hours, and you took the lens off and stained them, and they had a lens that was actually landing on the peripheral cornea or hitting the limbus with pressure, you will see a ring of staining
Yes,
on the peripheral cornea.
microcystic edema, microbulbar.
Microcystic edema.
Yep.
You got it. And then, of course, if that's the case, then you know that probably your lens is too small of a diameter. You haven't picked a lens that has a geometry which is consistent with the eye shape underneath it. And people say, well, can't you just increase limbal clearance? It's like, well, but if the area of the limbal clearance zone of your lens isn't in the right place, if it's not actually overlying the limbus, then it doesn't help, right? You're actually going to be then manipulating a curve. You're going to be creating more limbal clearance, but that's going to be happening over the cornea, not over the limbus.
Yeah, that junction point that's supposed to touch outside the limbus is touching inside the limbus, and so whether you hinge it up and down, it doesn't make a difference because you're still the
Still hitting in
outermost
the
point
same
is still
place.
landing. Your
Yeah.
chamber's too small in a sense.
Yeah. And so again, that's one thing to look for. And I do have a picture of that, but I don't have it on me right this second. But you will definitely see a very, very characteristic ring of epithelial bullae of microcystic edema. encircling the cornea, just barely inside the limbus. You'll see that ring. And that just means that your lens is just too small. You need a lens with a larger vaulting chamber. Okay, so that's the easy one. That should be a kind of a no-brainer. The harder one is when you overvault the limbus, right? And that's going to create this space. And I'm actually going to flick to a different picture here. And this is obviously a very over-exaggeration.
Mm-hmm.
But sometimes it's easier to imagine things when you see them at their extremes.
Yes.
Clearly, this patient, this lens is overvaulting the limbus badly. It's overvaulting. I mean, it's overvaulting a lot all the way to the edge. You can see where it's relatively white. That last maybe half millimeter all the way around is the only area where there's actual touch.
Yeah.
Or not touch per se, because the area above it that's all red and congested, it's touching the lens, but the lens isn't resting on it.
Mm-hmm. It's the gap that is pulling it. And it's almost like if there was more tissue there, you would see conjunctival prolapse, but because there's not excessive conj, it's just engorging, inflating, hypertrophy, like whatever you want to call it. I usually call it limbal thickening. That's kind of what I describe it to myself as, like, hey, there's a suction there that's pulling fluid into that area. And again, if there was excessive tissue, it would also maybe look like prolapse. But in this case, there's maybe not enough for prolapse, but it is pulling fluid in because of the displacement.
I would actually say, I think the reason why you don't see prolapse is there's actually so much room for the conch to just fill up the space that it doesn't have to move further. Sometimes when you get just enough clearance where you're like a little overvaulting, but you're not super overvaulting, then the conch sneaks under, but there's not enough room for it. So it just keeps going out over the corner. In this case, I think we've got so much space there that the limbus the conch just billows up right there. It doesn't even need to go up over the cornea. It can just sit right there and collect. So again, I mean, this is clearly a situation where we do not have a wide enough footprint, if you will, for the lens to be in contact with the underlying sclera. It's again like that spike heel effect. And so how do we fix this situation?
Yeah, when I look at this one, I would first maybe want to see it in primary gaze to know, I'm guessing it's probably decentered,
Definitely.
low. So I'd nudge that around to, see if I can get it to nudge again with all that like conj billowing and edema there. It might be hard, like this lens might be suctioned, pretty good. And I would consider, if it was feasible to the patient, washing them out for a few days and then trying on a different geometry of a lens. It looks like this eye is probably a PK of some kind in there, based on that scar. And so I would want to make sure that it's, oblate shaped lenses create space in the mid periphery, because that's usually what a graft looks like. However, maybe this graft is more prolate and it should have been a prolate lens so that it minimizes the shape in the mid periphery to reduce the space in that area, so we don't have all that space for that edema and that billowing to happen. So I would go back and look at my geometry on an elevation map or axial map, whatever helps you understand best. But I would want to know, even though it's a PK, does it really need an oblate shaped lens, assuming this maybe is an oblate shaped lens with all that extra space in the periphery. So I would go back to the geometry, and then even nasal temporal, there's a lot of space over the limbus. And so I would also be looking at a smaller lens or smaller chamber, just to make it all the way around fit better.
Yeah, I think it's critical, like you said, in this case, is we've got to look at this lens in primary gaze. But not only that, is we need to, once we're in primary gaze, we need to take and manipulate the lens and center it up so that it's sitting centered over the eye, because that's going to give us more clues as to what the lens is doing in relationship to the eye. A lot of times when you look at a lens like this and you see how decentered it is, you're going to say, I've got all this significant amount of limbal congestion. I've got this over vaulting, if you will, in effect, but superiorly, I don't vault. In fact, I touch the limbus. And so how do you fix that? And we know that, again, if we think about it, when this happens, it's really because the eye is toric and the lens is not, or the toricities of the eye and the lens don't match, they don't align. And so I always like to say, if you fitted a corneal GP lens on a patient with like 3 diopters of astigmatism, if you fitted them in a spherical GP lens, that lens is never going to center. It cannot, because there's a ridge going east and west across that cornea where it's elevated, and then it's depressed north and south. So the lens is either going to ride up under the lid and lift off and be a high riding lens, or it's going to release and drop and be a low riding lens. It's never going to center over the cornea when the cornea is toric and the lens is spherical. Again, small amounts of cylinder, yeah, if you have a diopter, maybe. But as you get up into higher and higher levels of toricity, there's just no way in the world that lens is going to center. It's either going to go up or it's going to go down. Well, the scleral lens, it's never going to go up, right? So it's always going to go down. So a lens that rides low like this it's just diagnostic of a fact that the eye itself has toricity and the lens either has none or it has not enough.
Yep.
And so in order to assess that properly, we've got to center the lens over the eye, over the cornea, and then reassess our clearances above, below, left, and right. And like you said, somehow adjust. Now, again, that could be a matter of in your horizontal meridian, maybe all we really need to do is flatten the edge a little bit. I don't know. If you flatten the edge, the whole thing will drop a little bit. You'll lose a little central clearance, but you will then land more closer to the limbus, maybe. But the bigger thing here, of course, is obviously this eye needs toricity in the vertical meridian, and it needs it not in the haptic because it's already got enough steepness at the edge. It needs it in the chamber.
Yes. Yeah. That's a great point. Looking at that edge blanching there, like if you steepen the edge to try and create more toricity, that's not going to help the edge. So you definitely need to put the toricity in a spot that decreases that excessive clearance in the chamber. Is it hard for you to go back to my first picture?
No.
Just because yours was like big. So yours was the lens is too big. And I look at, nasal there's like, or temporal on this one, you can see it nasally. There's that tiny bit of white ring, like right at the, that limbus there. And maybe that's an indication of mine being too small, perhaps, is like, there's that tiny bit of blanch, like right there. Maybe I'm touching or landing on the limbus with this lens.
That is honestly, because as we talked about looking at these slides and talking about them today, my initial thought was we were going to talk mostly about overvaulting the limbus, but when I actually looked at these pictures more carefully, I started to think, I wonder if this one's actually undervaulting and landing on the cornea.
Yeah.
Because you're right, they do get that kind of hazy, white ringish appearance around the peripheral cornea like that when you land on that area.
Yeah, and there you can see it like kind of superior nasal. So again, like maybe I'm just that tiny blanch there.
Might be just that tiny bit. Yeah.
I'd have to look back at this one. I know who the patient is, but to see like what I did to fix it. But you can get that redness in 2 different ways. And obviously the presentation is very different. Like I have no space. There's no, tissue billowing, conch hypertrophy, anything. There's just limbal injection, where yours obviously has that more space. And so again, like the chamber size and the centering, makes a difference.
And this lens centers pretty well.
And it would if it's like right onto the limbus there, it would center because
it will center. Yes. If you ever fit a lens that is too small, really tight, they usually center really well.
Yep.
So this could be that. And again, the way to check that, of course, is take the lens off, stain, look at that area out there where it looks almost whitish in the peripheral cornea, and look for epithelial disruption like a microcystic edema, and that would be telltale. And again, if most of the time just increasing limbal clearance alone is probably not going to be the answer, you might be able to get away with it, but you may have to go up to a larger diameter lens to remedy that.
Yeah, going back to like taking the lens off and putting fluorescein on the eye. Yesterday I had a patient that was complaining about, nasal awareness of the lens, and I look at it and it looks great, of course. And I thought the lens, I was like, I don't know. So I'm like, do I need to flatten the edge? What do I need to do? Like, you know, why? Or in my mind, I was like, well, he's complaining about awareness. So do I need to tuck the edge down a little bit? But then I take the lens off and he's got like a big old conj gutter there with fluorescein that you just didn't see it under white light. And so just another, you know, sort of reminder that taking the lens off, putting fluorescein on the eye, it'll tell you, it also will kind of show you if you are landing too close to the limbus too, because your limbus will kind of have this like very tucked up shape from that lens being too tight. So you'll see that, you'll see the microcystic edema. And so if you do have a lens like this that otherwise looks pretty good and you're not quite sure where to go, a lot of the times the fluorescein on an eye after lens wear will be helpful in pointing out those pain points too.
Agreed. I've got some other pictures I would like to show. And one of the things that I think people will look at an OCT or maybe even just looking at them at a lens on an eye and looking at the limbal zone to recognize when you're actually landing on the limbus versus you're actually just have contact with the limbus. And so, you know, this is a situation in this picture where hopefully you can see, I've got it marked there, where you can see the change in the lens design, where you transition from vaulting to contact, because there's more of an abrupt change in the back curvature of the lens in that area. And then if you can pinpoint that relative to the limbus, you can say, well, this lens, clearly the chamber is too small, because I can see where my lens bends and transitions from clearance to landing, or where it's supposed to transition, and then also where my limbus is. So that one would be an example of when you obviously have inadequate lens diameter. This lens needs to be made with a larger diameter. But and then here, of course, is the other example we were just looking at, which is when a lens really comes in with significant limbal clearance. And again, we've picked on the inferior quadrant, which is where this usually happens. But you can see just how much clearance we've got there now. This is going to create the problems that we've been looking at with the billowed up conjunctiva underneath the lens. With this patient over time is going to have the potential to have limbal edema and redness and all that engorgement, like in the picture that I showed you a little bit ago, that looked all fluffed up.
Yep.
But what's tricky is when you see a situation where you know where the transition from vaulting to landing is, and you know that you're landing beyond the limbus. And yet, when you look at the patient's eye and you look with like fluorescein, for example, you don't see fluorescein over the limbus. Or when you look at with OCT, what you see a lot of times is you see in the picture here where the suction effect under the scleral lens, it's pulling the conjunctiva in, is actually drawing the eye up, because again, we know that the cornea gets sucked up into the back chamber of the scleral lens over time. And we know that that's going to occur more peripherally than centrally. Okay, and because that's been studied, and there was a publication that came out some years ago that talked about how when you wear a scleral lens for a period of time and you remove the scleral lens, when you do topography right after removal, the cornea is flatter. Okay, well, why would the cornea be flatter? It's not because the central cornea has been smushed down. It's because the peripheral cornea has been pulled up. And so it's caused a flattening effect centrally because it's steepened peripherally. So what a lot of times happens is people will look and say, well, I don't have any limbal clearance here. The reality is you're not landing on the limbus, though. You're landing on the sclera conjunctiva. And because you have some degree of suction there, you're just pulling the limbal area up into contact with the back surface of the lens, which in and of itself is totally fine. It's totally fine as long as the lens itself isn't bearing weight on the limbal tissue. Again, if you pick the right diameter, if you know the size of the cornea and the limbal zone, and you choose a lens as a vaulting chamber, which is in excess of that, you should never have to worry that you're actually landing on the limbus, right? Then from there, more often than not, it's actually more about bringing down your limbal clearance so that you don't over-vault. I think over-vaulting is a bigger problem for me than under-vaulting, because as long as I'm picking the right diameter, I'm usually never undervaulting. I almost never increase limbal clearance. I'm more apt to decrease it more often than not. How about you?
I don't know if other than maybe a tilted graft, and I'm working in like an echo design where I
Yeah.
need to like crank up space, I would maybe increase limbal clearance, but those are less common. So your typical scleral lens fit, average PKs, KC, normalize. I can't think of the last time that I increased the limbal clearance curve. Always pulling it down.
And I just wanted to run through a couple of these real quick too, because these are kind of fun pictures. But these are just a series of different scleral lenses and how they approach their landing area and how much clearance they typically are built with over the limbus. And this is a picture. I think this is a Jupiter from some years ago. This is the old 15.6 design. And it's hard to see. I get it. It's not that easy. But if you look at where the lens lands and the amount of clearance that we have coming off the peripheral cornea, over the limbus into touchdown, it's a pretty gradual, or it's a pretty low approach. It's like the plane is coming in at a pretty close to the ground before it lands, as opposed to one where it's coming in at a steep descent. Not all lenses are made the same though. So here is an MSD design, and you can see this one coming in with a lot more limbal clearance. It's got more of a steeper approach to the landing. Okay. Here's a Zen lens, which again looks more like probably a Jupiter in terms of coming in low over the peripheral cornea into landing on the conj, and then a custom stable again where you've got again a different type of an edge profile, an edge shape, still kind of coming in low, but with that very rounded edge. And so it's helpful sometimes just to sit and look at lenses and understand the approach and the clearances they've got and how they're built for coming across that limbus, so that you can, again, I'm an advocate, as you know, of having as little limbal clearance as possible, but still not actually landing on the limbus. We don't want to land on it. We want to land beyond the limbus, but from that point inward, we want that clearance over the limbus and peripheral cornea to be relatively low as we can get away with without causing problems.
I totally agree. Kind of that tangential approach, just nice and thin, reduces fogging, lens movement is to a minimum. So I really like that. It just seems to keep the eye so much happier. And I would agree that, big vault, big problem, small vault, small problem.
Yeah. Well, anything else you want to do, or are we wrapping this one up?
Oh, that was a quick 27 minutes.
It was.
Flew through that. And I think those are good takeaways. And maybe we should make Jamie watch our session and she can come back with any
her own separate little
next time. We'll make her do her own podcast.
Make her do her own little 10-minute critique of this one.
Yeah. So
awesome.
Hey, if you have OCTs out there over the limbus, good or bad, why don't you send them our way so that we can talk about them next time? You can send them to our email there, overfilledthepodcast@gmail.com. You can send them to us on Instagram, overfilled_the podcast on Instagram. And you can catch us on Facebook too. You can send us those images either way. And if you happen to have one of our phone numbers, hey, text it to me as well. Love to talk about these clinical images, and would also love to highlight your photography ability if you're willing to send them our way. So again, great to see you all for this Friday. And Jamie and I will be traveling next week, but we'll be together. So maybe we'll do a podcast from abroad.
We'll find a time that works for the two of you, and I'll make it work for me.
All right. Sounds good. So thanks, everyone. Have a great weekend.
Take care.